Everyone. First, I'd like to thank Director WA for inviting me here today to talk about shockwave therapy to you all. Now, as you can see, I think you've all been told not to open the red envelope, so don't open the red envelope. We will be opening those before a colleague Michael Eaton does his presentation on hyperlaser. So you'll be instructed as to when to open them. So that'll be great, thank you. A bit about myself. As Scott said, I'm a trained physiotherapist from the UK, and then when I moved out to Australia, I was lucky enough to start working for Digio Global, and now I sell the equipment that I used to use as a therapist in the UK. So my colleague Chloe is here with us today as well, and if you'd like to come and see us during the afternoon tea break, we've got a variety of products there, and we can, and there's catalogues, and we can talk to you about what Digio all does nowadays. So, for the purpose of today's presentation, we're going to discuss shockwave therapy. Or for actually the purpose of today, we'll be talking about radio pressure waves, and that will become apparent when I show you the slides. We're going to talk about how it works, the clinical indications, contraindications and precautions, clinical protocols, different types of machines available on the market. Then we'll finish off with a couple of case studies before I ask one of you to very kindly come up, and we'll do a live demonstration using the shockwave machine. I think there's probably a few people in the room, certainly that I know of, who already have a machine. So it'd be nice for someone who hasn't ever felt what the radio pressure wave feels like, if they would like to offer their foot or leg for me. Not Evan, he's already told me he does not want to be. Anyway. So, I'm just going to turn this one. Karen. That's the There we go. Thank you. Okay, so we're firstly just going to talk about just to give you an idea of the differences. So we all probably know that lithotripsy on the right here is where shockwave all started many years ago with the destruction of kidney stones. That's been well documented. So nowadays we really talk about focused shockwave and radial pressure wave. So as you can see from the slide there, focused shockwave is where a wave is actually produced by a small explosion that's generated underwater inside the applicator. And this wave is focused through the lens and transmitted into the tissue, which you can see. Whereas a radial shockwave, that we now call radial pressure waves, which is the correct term, is a ballistically generated pressure, compressed air or electromagnetic energy. And this energy is used to drive the projectile, which you can see in the middle of the cylinder there, through the cylinder, inside the handpiece, and then produces the actual shock wave. So for today, we're actually going to look, the next slide will give us an idea of the difference between the focus and the radial, and then after that, we're actually going to talk about radial pressure wave today. It's more common in practice in podiatry. It's cheaper, so that's what we're going to do today. Anyway. So, how they differ is quite important. So the characteristics of a true shock wave, as you can see from this graph on the left, so the bottom graph is the focused shock wave pressure. So it's a very fast, sharp rise in peak pressure, followed by a negative pressure, which is what we call cavitation bubbles. And those of you who are au fait with focused shockwave will understand that. Whereas if you look at the radial wave, which is the top graph, the shape's quite different. So There's less pressure, but it's over a much longer period of time. And that's why we call it an actual radial pressure wave. And you can see by the picture on the right here that the point of maximum energy is different between the two. So where the energy is delivered on the focused shock wave is obviously much deeper than on the radial. And then obviously gives off different biological responses. So, as I said, we're going to talk about radial pressure wave. How does it work? So, as I said to you, pressure waves are generated by compressed air. And the compressed air drives the projectile in the cylinder to the shock transmitter. And this energy converts into acoustic energy when the projectile hits this transmitter, as you can see on the picture here. The transmitter is in contact with the skin, and the gel is used obviously to propagate the energy into the tissues. And the sound waves obviously then create the biological response that we're looking for to make a difference to our patients. Okay, so there's 4 main biological effects of a radial pressure wave. So we're going to look at each of these, but we don't have much time today, so we're just going to brush the surface. If any of you are keen to delve more into the physiological processes of radial pressure wave, then feel free to come and speak to myself or Chloe at the break, and if you give us your emails and what have you, then we can share the PowerPoint, or I can give you some more reading material for you to find more out about it. So we'll look at biostimulation first. So mechanotransduction, or biostimulation, is it's a normal occurring process in healthy tissue. But obviously, as podiatrists, are not the reason your customers are coming to see you is because they've not got healthy tissue. So basically, what the radial pressure wave is doing is essentially acting as an external mechanical stimulus. And we can use the radial pressure wave to influence the cellular makeup in the tissue, and then influence the tissue with our normal exercises and loading that we've all been taught how to do at university. The second biological effect is the pro-inflammatory stage, and this is where radial pressure wave has become so common in a lot of clinics now. So for tissues to proliferate and remodel, we need inflammation to occur. And after shockwave therapy, there's evidence of pro-inflammatory markers in the tissues. So we know that something is affecting the cells. And in chronic tissue, the normal healing cascade is stalled. So essentially what we're doing is actually just rebooting the system. So we're taking something out of its chronic stage and trying to reboot it to heal. And that's the easiest way to look at it. The next biological effect is angiogenesis. We all know that tendons have a poor blood supply, which is why they have such a difficult time healing, and it's your job as podiatrists to have an input into making that better. So you can read up there what it says, but basically the radial pressure wave improves the levels of nitric oxide in the cells, and this release promotes vasodilation. There's some nice articles that I can give you if you're more interested in finding out about the angiogenesis. The fourth biological effect is pain relief, probably the most important in terms of why our patients come to see us in the first place. So there's a longer lasting analgesic effect is achieved when radial pressure waves are used as an oxystimulus. And the oxystimulus is responsible for the release of substance P in the cell. And the radial pressure wave dilutes the presence of this at the site of the injury, resulting in your reduced pain levels. you can see on the right here how we've crossed out this horse. So basically, radio pressure waves are now banned from being used in the horsing world 48 hours prior to a race due to reducing the pain level. But I guess, as Neil Hall and I discussed yesterday, how you prove that is the case, it's probably not very easy. Okay, clinical applications. So there's an international society for medical shockwave treatment, and they have conferences all around the world every year, pre-COVID, every year. And they have approved clinical conditions for the treatment of radio pressure wave. And what they mean by that is that they've been internationally researched by separate bodies. So it's not that DGO or any of the companies that sell radio pressure wave have done studies. It's independent research. So you can see here, there are approved conditions: radial trochanter, pain syndrome, patellar tendinopathies, Achilles tendinopathy, and plantar fasciitis. But obviously that's not the list of what we can actually achieve and change with our patients. So here's the clinically proven indications, and what that means is that these conditions have actually been researched enough that we as practitioners can confidently treat these tendinopathies and muscle pathologies with the radial pressure wave. So you can read the list yourself. I think more importantly, where I've added Ledderhose disease at the bottom is quite a recent article that's just been published that I'm happy to share with anybody that's interested, and obviously is related to the connective tissue rather than muscle pathologies or bone or tendinopathies. So I think you can see that radial pressure waves having a huge influence with a lot more conditions than I think originally we all thought that you only use shockwave for plantar fasciitis and Achilles tendinopathies. Okay, contraindications and precautions. As therapists, we all know that there are a few contraindications and precautions to using any electrotherapy agent, and it's no different with radial shockwave. So on the left here are the contraindications, which you would think in any electrotherapy agent being used. So malignant tumour and pregnancy. I'm always asked if I have a pregnant patient and can I treat their plantar fasciitis? Legally, yes, is the answer, but I think we just need to all be aware that if someone's pregnant, you just need to be careful. And on the right, we have precautions that are generally what you would normally know or think about electrotherapy agents. Apart from probably cortisone injections, it's been well documented that you cannot radial pressure wave a patient within a 6-week period of them having a cortisone injection. And this is just because of the pain relief factor. Am I going at an okay speed? Just tell me to slow down or speed up. Or clinical protocols. So this gets down to really what we're trying to achieve using the shockwave. So once we have a bit of a demonstration for those of you who've never seen it in use, you'll understand better. But basically we use what's called bar pressure as an intensity. And the 2 bar pressure is the minimum bar pressure for a therapeutic effect when using a machine. And the machines on the market go from 1.6 bar pressure to 5 bar pressure. And that's just a force that's being produced. Pulses are the amount of times that the projectile is moving in the handpiece, and the research has been done that proves that you do 2,000 bar pressure, 2,000 pulses in any one treatment. So our machines actually cut out after 2,000 pulses, so that you can't over-treat the patient. Frequencies, the hertz, obviously, the lower hertz gives a deeper effect, and the higher hertz is for the more sensitive patients. And once you have a play with it, for those who never felt how it feels, you'd understand what I'm talking about. Treatment time frames. The first treatment should be administered only once in the first week, because we're obviously trying to cause this pro-inflammatory reaction. So we don't want to be over-treating the cells and tissue. And like any allied health professional, you don't want to keep treating if you're not making a difference. So I personally, if you've no change after 3 sessions, I would be considering that it's either not working, or the wrong pulses are being used, or intensity, or perhaps that patient needs to have different treatment modality. Post-treatment recommendations. So as I said with the pain relief, 99% of your patients will actually experience an immediate reduction in pain post-treatment. And for those of you who've already got a machine, correct me if you don't agree with that, but 99% of your patients will feel an immediate relief for the reasons we've already discussed. For this reason, you need to be quite careful with the level of support undertaken by your patient on the same day as treatment. So they certainly don't want them going out for a 5K run or anything. It's a gentle exercise. I think I've covered. Yeah, so active rest, and what that means is a gentle walk, really. Ice is not recommended because obviously you're trying to make the tissues more inflamed, so if you're icing them, you're kind of counteracting what you're trying to achieve. Has everyone read that? Okay, now we move on to the different types of machines that DGO sell. So on the left here we have our Intellect machines, and then the mobile range. And then on the right we have our latest, we call it our entry-level Shockwave, and I'll explain a bit more. So this is our latest machine. We're going to use that today to treat one of you. So why is it so good? It's got a touch screen. The new handpiece has come onto the market and enables us now to have 21 different transmitter heads. We'll just go through quick. We'll touch on the transmitter heads in a minute. It's slimline, as you can see, and if you're only treating in one practice, it doesn't take up much room. Okay, so this is our mobile unit. So it's very handy for clinicians who move around. So if you work in a variety of clinics, this is probably the machine for you in terms of the power it produces and its availability to be moved around. Okay, the transmitters. This may look mind-blowing for those of you who don't have Shockwave. But basically, on the right-hand side here, we have the trigger point / tendinopathy transmitter heads. How are they different? So they're all made of a different material, and that material relates to how well they administer the radial pressure wave into the tissue. And those of you who can't, I don't know if you can actually see the small print, but I'm happy to send you this PowerPoint, and it gives you quite an in-depth description of what each one would be used for. In simple terms, the smaller the diameter head, the smaller the area that you'd be treating. In the middle here we have the fascial treatment heads, or commonly known as the periactors, and I'm just going to go through them in a minute with you. And that's just how they're assembled. So here we have, so effectively, this is all quite new to us because we've never had a handpiece before that these periactors fit onto. They're effectively what we all have in our practice. So we've all got our hands for massage, or massage guns nowadays, foam rollers, and some practices have these scraper massage tools. So that's effectively what these periactors are. And you can see I've just put a picture at the bottom. If you were using your hand, then that's the tool you would be using attached to your radio pressure wave machine. And that just gives you a visual of what they're trying to achieve. Okay, this is the radio pressure wave light. So this little device was brought onto the market for pain relief mainly. It goes through 2.7 bars, so as we've already learned, it's therapeutically beneficial. It's lightweight, easy to use, but you can only have a choice of 5 transmitters using this, and obviously it's not as powerful. But those of you who've got machines at the moment will probably know that the 5-bar pressure is very rarely used, as the patient's unable to tolerate that high pressure. And so for someone starting out, this is a nice little machine and you get nice results with it. And the transmitter heads that go onto it. Okay, so I've got 2 case studies that were very kindly given to me by 2 podiatrists that work in Perth, neither of who are here today, I don't think. So the first case study is a 47-year-old woman, partial tear to her left Achilles 2 years prior, complaining of pain in her heels and the back of her legs for a few months. She'd been on anti-inflammatories for 4 weeks, with obviously an excruciating level of pain, waking at night due to the pain, and I think she'd come into the clinic on crutches. She'd had an ultrasound which showed bilateral plantar fascia with her and left Achilles tendonitis. No tendonitis on the right, but there was evidence of a previous tear. So she was treated weekly with radio pressure wave at a bar pressure of 2.6. So again, just showing you that sometimes the little machine is sufficient power. So week 1, there was no change in her pain, but she wasn't taking anti-inflammatories. By week 2, walking was less painful. She slept every night, and her pain had reduced to 6 out of 10. Week 3, 3 days of no pain. She was starting to exercise, and the pain had reduced to 4 out of 10. Week 4, minimal pain all week, just pain when she first started walking, and she had obviously previously been fitted for orthotics, and they arrived week 4. Week 5, she'd had 1 day of pain, but she'd obviously been on her feet all day, whether she'd gone back to work. So that's case study 1. My other case study is a 25-year-old soccer player who'd had a 3-month history of constant pain in his heel, only playing the sport though. The pain reduced when he was non-weight bearing. He'd been icing his injury, but still playing. Unable to walk barefoot, with a pain score of 6 out of 10. He'd tried a bit of self-massage, but hadn't gone for any podiatry treatment up until then. So week 1 treatment is tolerated over the tender area and surrounding tissue. Again, as I explained, immediate relief, but only lasted for a few hours. Week 2 was treated twice. Immediate relief that lasted a few days this time. In treatment 3, hadn't had much pain for 5 days and managed a short walk on the beach. So that was a huge improvement because he'd been unable to be barefoot up until then. After treatment 4, the pain reduced most of the time, so he was down to 1 out of 10 pain scale. So I think what is important to understand with any of these electrotherapy agents, as we all know, that it is an adjunct to therapy. It's not to be used solely, and that our exercises and our clinical expertise is an essential part of their rehab still, and this is just a helping tool. And as I said, we're trying to reboot the injured system. Clinical resources. So at DGO we have a lot of availability to allied health professionals in terms of research. So there's all sorts of research papers, and you're welcome to any of this. You can go onto the DGO store, and there's a clinical academy now. And with that, with the year we've had with COVID, we've got all sorts of webinars on that you can feel free to have a look at. There's a DGO Shockwave Therapy book that's available to you, if you speak to me nicely. And then when and if you purchase a machine, there's all sorts of brochures. Those of you who've got machines will know that there's posters and flyers that you can give to your referring doctors or GPs. So I just want to finish off with this video that basically shows you the power that is being generated from the transmitter head. And we've got a coin here, so just show you the power. And at each time the video plays, it will tell you what power is being administered and which transmitter. So you get an idea of what power each different type of transmitter is administering. Evan. So that's just your normal stainless steel transmitter head. Use 5 bar pressure. So this is 1.6 bar with deep impact. So you can see that goes higher than the 2.6 of the normal. And here's the high bar with the deep impact. Your poor patience. Thank you, Evan. Okay, so that's the end of the presentation.
To go to my surgery.
Yeah, now you're going to watch a video. Yeah. So now, I'm not going to pick on anyone as long as someone puts their hand up to come in. Does anyone actually have a pathology at the moment? Oh, there we go, perfect. Have you got a radio pressure machine?
We've got a Shockwave machine.
Yeah, sure. Focus?
Focus.
Oh, you got focus, okay. Okay, what's your name? Fred. So Fred's going to be very kind and come up. Where's your pathology? What's
Left planicle pain.
perfect. Okay. So while Fred takes his shoes and socks off, feel free, I know there's not much room, we can pull the bed out slightly, come around if you want, or stand up. I'm not sure you're allowed to stand in the chairs, but you can stand up and come and pull it. Thank you very much. Now, it's probably best to put it onto the patient rather than onto your transmitter head. And I only say that because then if you're new to it, to using Shockwave, and you press the button to start and you've put lots of gel on, it'll fire all around the room. And that's just from previous experience. So obviously you'd be up and down, and you may not be standing like I am, but anyway. So really then, you're ready to go. So again, like I said, we're going to have it low. You can then put it up as you go once you've spoken to your patient and it's not uncomfortable enough. So is there anyone in the room who's actually never heard the noise? Okay, so you'll probably get it. It's quite loud. And I would say that it's probably not a great idea to have a shockwave machine in a clinic where you don't have separate rooms, because you're going to scare off the other patients probably. So you can see, so it's a compressed air system, like I was talking about. And then your button here, and I'll just, for those of you who've never heard it. Now in a big room like this, it doesn't sound too loud, but you can imagine if you were just in your little normal clinic, it's, it can be scary for the patient. Now, I'm just going to let this run. Okay, so we're just going to administrate. Now, you can hold it, however, just because I'm a physio, I like to kind of get close to the tissue. You can hold it like a gun if you want to. Okay. And all you're doing is just a small circular movement. How does that feel?
Quite gentle.
Sorry?
It's quite gentle compared to the one we have around.
Can't get up. So what you can do is you can stop that. That's at 1.8 bar. So we'll put it to 2.4. I try and jump like that. And again, how are we doing? More? 3, yeah, I'm putting it to 3. Okay?
Yeah.
More, or is that enough?
No, that's good.
That's good. So you would do your 2,000 pulses. Then if you felt they had like a fascial tightness, or you could do another 2,000 pulses. What the research says is never do more than 6,000 pulses in one treatment session. So with the heel spur, they might have tight gastrocs. Then you would put onto muscle treatment, change the head. So just to give you, so the heads just come off like that, and as you can see there's different heads. You would just change your head. Now, as I said, it's an adjunct, so you wouldn't then, thanks very much, and out the door. Make sure that they know that they're doing their eccentric loading or whatever other treatment that you're doing. What I would say, and just from experience, that if you are doing radio pressure wave, shockwave, then don't do your dry needling in the same session, because you're not going to have any idea of the effect of which one is working better.